Well, hello. Welcome to GHAPP MASLD Community Network podcast. My name is Lisa Richards. I'm a nurse practitioner. I practice in San Diego, California. So today's podcast, we're going to concentrate on HCC surveillance, implementation in patients with advanced fibrosis and cirrhosis that have MASH. So the first question is, which patients with MASH require hepatocellular carcinoma surveillance based on their stage of fibrosis? And specifically, we're going to look at stage 3 and stage 4, that is advanced fibrosis and cirrhosis. So according to AASLD guidance, the amount of liver fibrosis in patients with MASLD has been strongly linked to the development of liver-related outcomes and death. Bridging fibrosis, cirrhosis, are associated with an exponentially greater risk of liver-related morbidity and mortality. Now, in my practice, I do surveillance on patients with advanced liver fibrosis, that is stage 3, and patients with cirrhosis, stage 4, every 6 months. However, AASLD recommends against guidance routinely on patients that have stage 3 advanced fibrosis. The next question is, what is the recommended modality and frequency for HCC surveillance in eligible MASH patients? So if we look at AASLD guidance, HCC surveillance should be performed at a semi-annual, approximately every 6-month interval. This recommendation was initially based on HCC tumor doubling time, although subsequent analyses demonstrated semi-annual surveillance is associated with earlier tumor stage and improved survival. HCC surveillance should be performed using ultrasound and AFP approximately every 6 months. And I think it's important that the APPs be aware of the visualization score. So when you're looking at the imaging study, you want to look at the LIRADS, the liver imaging, reposting, and data system score. A score A means minimal limitations, and so repeat surveillance is recommended in 6 months. A score B means that there was moderate limitations and that repeat surveillance should be in 3 to 6 months. A score C means that there were severe limitations with the study, and so they recommend a contrast MRI or a multi-phase CT. Now we'll discuss the practical challenges in ensuring adherence to HCC surveillance schedules in MASH population. So specifically, we'll look at patient awareness, access to imaging, and follow-up. I think it's very important that patient awareness is something that we focus on as APPs. We want our patients to understand their liver disease and the risk of developing liver cancer. We want to empower them so they're actually partners in their care. When patients are informed, they are better equipped to take an active role in their care. So by knowing the importance of regular liver cancer screening, they can confidently ask their healthcare provider. Perhaps their PCP is doing screening. Isn't it time for my ultrasound now or my blood work? So again, empowering the patient through awareness, I think, is paramount. Why does this matter? Early detection of liver cancer significantly increases the chances of successful treatment and better long-term outcomes. What can help? Well, we can ask the patient to maybe set reminders. Many patients have smartphones. So let's set up an appointment reminder or an imaging reminder on their smartphone. Have them talk to the provider to see if there's any barriers and identify potential barriers. Is there financial problems or is there transportation service problems that they need assistance with? So I think that would be important to try to identify barriers or obstacles that may not allow them to do the every 6-month screening. And then finally, how should APPs manage the finding of a new liver lesion on surveillance imaging? So according to AASLD, if you have 1 centimeter lesion, greater than or equal to 1 centimeter lesion seen on ultrasound, or an AFP that is greater than or equal to 20, or an increasing AFP, then they recommend a diagnostic contrast-enhanced multi-phase MRI or CT. Now, if the results of the multi-phase MRI CT is positive, then in my practice, we review at a liver conference board to look at further recommendations. For instance, is this patient a transplant candidate? If this patient's not a transplant candidate, then potentially are they a candidate for local regional therapy, and a referral to IR interventional therapy would be indicated. So hopefully that answers some of your questions regarding HCC surveillance. My name is Lisa Richards, and I want to thank you so much for participating today.